Hello, my name is Albert Wu. I'm a professor in the Johns Hopkins Bloomberg School of Public Health in Baltimore. And I'm going to be talking to you today about responding to adverse events. You can see my bio, but I think the most pertinent details are that I am a practicing general internist in the Johns Hopkins Hospital, though I'm really only a physician on Friday mornings. The rest of the time, I'm a professor of health policy and management. I also spend quite a bit of my time in the Armstrong Institute for Patient Safety here at Johns Hopkins. And I've been working on patient safety since about 1988. You can see the rest online. I have no particular disclosures. So the learning objectives for this lecture are, at the end of this session, I hope that you will be able to state the immediate next steps to be taken after an adverse event occurs. You should be able to describe at least two elements of an effective disclosure of an adverse event to a patient and or family member. And you should be able to define what the term second victim means. Here's a story of an adverse event. And this is something that could have happened to me. I recently had a slightly unfortunate incident of a retinal hemorrhage. It turned out it was from a spontaneous retinal tear, and I ran to the ophthalmologist, and they said, we can treat that with laser therapy. This was done in a chair, just minutes after the diagnosis was made, and it was a little bit uncomfortable. What the physician did was to essentially shine a laser pointer on steroids into the back of my eye and coagulate a number of spots to prevent further bleeding from, further tearing from occurring and further bleeding from happening. I was worried that what they said was, hold still. And I was a little bit worried that they might coagulate the wrong point. What if they were to actually zap my macula instead of the periphery of my retina where they should be? Imagine that happened. Imagine that they nicked a bit of the macula, and when I came out of this, I in fact had a visual defect, a deficit. So should they tell me what happened? So what to do after an adverse event? Turns out there's really widespread agreement that patients should be told about adverse events, including those caused by errors that occur in their care. This is one of the rare times when there is consensus among virtually all of the stakeholders. Professional societies, ethicists, lawyers, and policy all concur. In 2015, the National Health Service of England instituted a duty of candor, which stated that physicians and hospitals should report errors at an early stage so that lessons can be learned quickly and patients are protected from harm in the future. This also matches very closely with what patients would want. In repeated surveys, virtually all patients want disclosure of all harmful errors, what happened, how they can be prevented, and a full apology. So what actually happens after an adverse event? This is all very well and good, and providers, I think, when surveyed, will all endorse the fact that, yes, indeed, these things should be disclosed. However, there are personal, practical, and cultural barriers to disclosure, including, especially in the US, but also in many other countries, fear of malpractice litigation, fear of being sued. It really isn't human nature to disclose one's failures, particularly if those failures harm someone. And this is a powerful instinct of self-preservation to overcome. So physicians do agree that harmful errors should be disclosed, but they worry about the consequences for themselves and tend to choose their words carefully. And as a result, many disclosures are withheld entirely, or they're incomplete. The patient may be told that something happened, but not that there was an error, or not that the physician was responsible. And as a result, patients suffer from uncertainty and anger at having the truth withheld. Here's a little bit of an algorithm for what to do after an adverse event. And I would say there is no real recipe or cookbook for exactly what one should do, but bear with me and we can go through this. This flow diagram begins with the recognition of an incident. At that time, it can be ascertained whether or not there was harm, or might have been harm, or no harm. If there was harm, of course, the first step is to take immediate action to mitigate that harm. And these are primarily clinical steps. This should be done immediately as part of the continuing process of taking care of the patient. However, as soon as possible, steps should be taken to figure out what happened and to notify the patient and family. In the US, this involves contacting risk managers in the hospital who will initiate an investigation. Steps should ideally be taken when things are figured out to make improvements and to improve safety. Notifying the patient and family should happen, again, in as much real time as possible, as if you were simply telling them about something that happened, however unfortunate. This is not a one-time discussion, but should begin a continuing discussion and dialogue with the patient and family about what has happened since. In the case of a no harm event, which sometimes is called a close call or a near miss, I think that there is really agreement that disclosure is discretionary. There, in fact, in some cases and in some environments, the ICU, for example, where there may be many, many near-miss events from which there are recoveries, and it's simply impractical and would be disruptive to tell the patient about every single one of them. On the other hand, patients can really benefit and paradoxically can have more trust in their physicians if they have an honest discussion about what is going on and what could have happened. What are the elements of a good disclosure discussion to the patient and perhaps their family member? Patients want a number of things. First of all, they have a real hunger for information. When things go wrong, there's uncertainty, and that uncertainty can be very uncomfortable. People want to know what happened, and so they should be given a description of what happened. No more and no less than what actually is the truth. They would like someone to take responsibility to the extent that that makes sense. In most cases, as you well have learned, most errors and adverse events, in particular patient injuries, are multifactorial. There are many contributing factors at many places in the healthcare system. You can explain that to patients. They can understand, but they do want people not simply to pass the buck. It's very important to patients that actions be taken to prevent this sort of thing from happening to others in the future. I think that we have all bought in to the fact that healthcare should help and not harm people. And this belief is so strong, people can't tolerate the thought that an error might happen and not be learned from, that improvements will not be made. Patients really want and expect a sincere apology. And finally, in some cases, it may be appropriate for some sort of settlement to be made with the patient, some sort of financial settlement, which in many cases may forestall a lawsuit. So there's another side to adverse events. And this graphic is from the cover story of an article in the Johns Hopkins Medicine Alumni magazine, in which they talked about the impact of adverse events on providers, on doctors, nurses, and other healthcare workers. And the fact is that we as healthcare providers have very high expectations for our ability to help patients. And it's very difficult for us to understand or consider that we sometimes make errors or that things go wrong. In addition, there are many surprising and disappointing things that happen in healthcare. And it is quite obvious, I think this is sort of a truth that's been hiding in plain sight for as long as we have been practicing medicine, that healthcare providers themselves can be harmed, can be traumatized when their patients do badly, have unexpected adverse events, particularly those that are caused by our own errors. They may become second victims of the same incidents that harm patients. A definition of the term second victim is a healthcare provider involved in an unanticipated adverse patient event, which may be caused by a medical error, but not necessarily, who is themselves traumatized by that event. The trauma to the provider can be made worse by a number of factors, including a critical peer response from colleagues or from supervisors, the process of investigation, which may be very logical, and in fact, we should be proud that we've gotten good at doing investigation, but can be quite excoriating to the providers themselves, who may just be recovering from their experience of the incident. And finally, it can be almost everything is made worse by litigation, and virtually all physicians, in any case, fear the possibility of a malpractice suit, even in cases when it's unlikely. Healthcare workers can suffer short and longer-term symptoms after an adverse patient event. Immediately afterwards, they may feel numb or confused. They may have a sense of detachment or even depersonalization. Certainly, they may be grief-stricken or even depressed and may withdraw as a result. They may become highly agitated or anxious, and this may persist. As a result, they may have problems sleeping. They may have flashbacks or otherwise re-experience the event. In subsequent days, they may have physical symptoms. They feel inevitably shame, something I think healthcare workers are very prone to, guilt, and self-doubt. Can I do this job? Should I continue to be doing this job? As a result of all of this, they may not be functioning at the top of their ability. This, in fact, can lead to further errors and further patient harm. I first wrote about this phenomenon in the year 2000 as part of the special issue of the BMJ that was published that year about medical errors. It's taken more than 15 years for this really to catch on, but this year in 2018, the Joint Commission of the US issued what they called a quick safety alert on supporting second victims. They wrote, when a patient suffers an adverse event, many people are affected: the patient, family, and healthcare providers. The provider most directly involved in the event becomes the second victim. I would add that many providers could become second victims. While the patient and the patient's family become the priority for the healthcare organization, the provider may be emotionally traumatized by the event and have lasting effects that persist for months or years afterwards. They go on to say that all healthcare organizations should make provision for supporting healthcare workers after adverse events so that they do not suffer further and so that healthcare does not also suffer. At Johns Hopkins, since 2011, we have been running a program which we call RISE, which stands for Resilience in Stressful Events. The mission for this group is to provide timely support to employees who encounter stressful patient-related events. That mission statement is carefully crafted. We would like to be able to provide support that is when the provider needs it. When someone calls, we try to respond within 30 minutes, and we try to meet with them within the same day. We support employees, not simply doctors or nurses, but all kinds of employees. There are other healthcare workers, food service employees, sanitation workers who have patient contact and who may also be traumatized after a patient has a bad outcome, even if they are not involved in any way. And we're interested in stressful patient-related events, not just errors. In fact, the majority of bad outcomes just happen because there are many bad outcomes in healthcare, particularly in hospital care. Some of these may be surprising or disappointing, or simply sad, and people can be emotionally scarred by these. Our RISE team includes about 35 very multidisciplinary healthcare workers, including nurses, doctors, chaplains, social workers, technicians, and others. They are on an on-call rotation. At least 2 people at any given time are holding a pager or a virtual pager. The service is entirely confidential. People may call or activate online the system and are called back. We do not report to anyone, including managers, risk management, or even the patient safety office per se. The service is entirely to provide what is essentially emotional first aid for the person who calls. As of 2018, we are getting perhaps 10 calls per month. Though occasionally we get that many calls per week. And the evidence that we have thus far is that this program is both beneficial to the callers and also saves the institution money, perhaps $20,000 in one study for every time there is a call. Tom Bodenheimer wrote a few years ago that healthcare may have four aims. It's been written before by Don Berwick and others that the three aims of healthcare are to enhance patient experience of care, to improve the health of populations, and to reduce the per capita cost of healthcare. But Bodenheimer wrote that a fourth aim is to maintain the well-being of the healthcare team. This requires providing support in both an informal and an organized way to healthcare workers. I think it's quite obvious that in order to deliver high-quality healthcare, one must have a healthcare team that is themselves healthy, happy, and able to be their best selves in delivering that care. So this concludes our lecture on responding to adverse events. I've provided a few additional references for those who are interested. Thank you very much.